That's true, and we actually understand the physiology of that very well. When any of the primary headaches can have so-called cranial autonomic activation, where the nerves that produce nerves get activated that produce eye watering or redness or nasal congestion, feeling of fullness here or feeling of fullness in the ear. That's cranial parasympathetic activation. We know the anatomy and physiology of that, and it can make it look like sinusitis. But sinusitis is not photophobia, phonophobia, nausea and so on. So that when you hear something that sounds like migraine but has these sinusy symptoms, it's actually most likely to be migraine with cranial autonomic features.
Okay. Finally, two other areas I just wanted to look at is, first is the trigeminal neuralgias, or the neuralgias. The trigeminal neuralgia is obviously the one that most of us know about. Features of trigeminal neuralgia, you can't really miss it, can you, or can you? Are they going to be fairly straightforward for the GP?
It's a pretty stereotyped condition. Short, jabbing, electric shock sensation, second or third division, usually triggered. But that's it. I mean, it's not interparoxysmal, inter-attack pain. It's not diffuse. It's short and it's sharp, it's triggered, it's an electric shock. That's it. Very often you see people labelled with atypical trigeminal neuralgia, where they've got pain in the face, from other things we've been talking about, and they get this label of atypical trigeminal neuralgia. The thing about trigeminal neuralgia is it's typical. So if you're going to apply the label atypical, probably what you're saying is it's not trigeminal neuralgia. So it's worthwhile standing back from that. When you're tempted to write atypical down, put your pen down for a second and ask yourself the question, is it atypical because it's something else?
And it's always unilateral?
Yes.
Do you ever get it in the first division, or is it always...
10% in the first division.
Right, so you can mistake it. It can be a bit of a diagnostic dilemma for GPs if it comes in the first division.
Exactly. But pain-free in between times, triggered, short, electric shock-like sensations, boof, like that. And that's it. Nothing else or nothing else.
How many cases are caused by compression of the trigeminal? Are they all compression, or are there other causes as well?
Well, the largest group have this associated vascular anomaly that's led to this treatment of microvascular decompression. And if you take the typical trigeminal neuralgias, then that finding is relatively common. If you start moving into atypical, which I think is not trigeminal neuralgia, then the finding becomes less common, and the outcome from the procedures becomes much, much worse. And it's a posterior fossa surgery, so that's significant. So in patients who've got the typical syndrome, they need to get along to the neurologist and eventually to the neurosurgeon and have the investigation. In the atypical ones, they actually need a diagnosis.
But in the first instance, carbamazine is our...
Yep.
And the natural history, do they settle down, or should the GP refer everyone with trigeminal neuralgia?
Well, as you say, that usually they'll respond to carbamazepine, they'll do quite well from it, and that's almost, it's not diagnostic, but it's typical. I think that it's fair for the patient to be able to have the conversation with the surgeon, have the investigation and have the conversation about the surgery to get the information, because I think they're entitled to be able to weigh up the prospects of taking carbamazepam over years, which is typically what they'll have to do, versus the prospect of not having to do that but having a serious surgery. So I think it's a rare enough condition that we should be letting people should be able to at least have that information.
And of course there are these other much rarer neuralgias that can really fox us. Do you want to say a little bit about, just to have in the back of our mind?
Yeah, glossopharyngeal neuralgia, the jabs in the back of the throat, that is very rare.
Right. Okay. So
if you see one every 5 years in a national referral service, you'd think Christmas was coming.
Of course, they might be more common out there. It's just that GPs don't recognise them and they don't refer them in.
Yeah, that's true. I think on the whole in the neuralgia business, it's the trigeminal neuralgia, for example, is a bit overdiagnosed rather than people don't refer it in.
Okay. Let's finish off with something that's very common, affecting probably 3% of the population. That's medication overuse headache. I mean, is this being recognised fairly recently? I don't seem to remember in my early medical career that it was knocking around at all, or that was my ignorance, or is it just being recognised?
Well, you can go back, as with most things in neurology, and read Gowers from the 1880s, and I'm only saying that in retrospect because other people pointed it out to me, or other medical textbooks, and our forefathers recognised that there was a problem with regular, typically opioid use at that time. So I don't think it's new, but like I think it became perhaps was less recognised and it's had a reappearance in its recognition. But if you look in the literature, I don't think it's particularly new. I like to think of the term medication overuse as being first before I use the term medication overuse headache. And the reason for that is that medication overuse has a clear definition and it doesn't always lead to headache. And I think that's useful because if you tell a patient that if you stop doing this, your headache will always go away, you won't be right. And one needs to be a bit cautious about that. So I say to patients that, for example, you're using a codeine containing a painkiller on 10 days or more per month. So you've got medication overuse by definition. Now that may be producing headache and it may be inhibiting preventives work, and we should work through that problem. But it strikes me that it's attractive to say in the first instance you have medication overuse and not tell them that they're going to get necessarily better from stopping it necessarily. Just keep your options open a little bit, because if you say that to someone, you've got medication overuse headache, and they stop taking codeine and they've still got headache, then you're a little bit gone up the post without a way down.
But usually medication overuse headache doesn't come out of the blue. It starts with some headache phenotype, usually migraine, have increasing frequent migraine, so there's always an underlying problem there, isn't there? So by the time they get to their GP, they'll have this sort of murky overuse headache plus a bit of spiky migraine, so it's very difficult. But usually there is, if you go back in the history, I find there is always something to see in the past history that's been getting more frequent and caused this problem.
Yes, that's typically true. Just about everybody with medication overuse problems, medication overuse and frequent headache, shall we say it that way, has a personal or family history of headache, troublesome headache, and very often that'll be migraine. And that's true. The point I want to make, I think, is that while no doubt some people who are overusing analgesics have headache induced by that, not all people who overuse analgesics will have a headache induced by that. And so we have to be careful a little bit to dissect that out. I think we could all agree it's easy to get a patient to agree that they should take less tablets. And very few people want to take more tablets. But to then set up the expectation that they'll be wonderfully well when they take less tablets, one has to be cautious about that.
I mean, do we know what's going on? Do these people, if they take painkillers for their back, do they develop headache? Are they headache-prone individuals? Do we have any idea of the pathophysiology of medication overuse? We
have some indications from some studies, one that we did and one that the Canadians did. So if you go to a rheumatology clinic where patients are taking these analgesics for another indication, then about 10% of people in a rheumatology clinic will have daily headache and be medication overusers. They'll all have a personal or family history of migraine. This is in the studies that have been done. Another 20% will have a personal or family history of migraine. They'll be overusing by the criterion that we've used, and they don't have headache. So it strikes me that and that's the sort of experiment, feed everyone analgesics and see what happens. So it strikes me that there's a group of migraine sufferers, maybe about a third of them, big picture, who are prone to medication in overuse headache, and another group of them where it actually doesn't make any particular difference. And we can't dissect that out at the start. It's a great research question. What's interesting in that data is that there's no good evidence that non-steroidals will produce the headache part, the medication overuse headache as such. And that's a real red hot topic as to whether one should be having this medication withdrawal process for non-steroidals as well.
I thought they were still implicated. I mean, codeine, paracetamol.
Codeine is way up there. It's pretty clear.
Opiates are the main thing.
Opiates are the big ones. Opioids are the big ones. Triptans that's clear as well. Ergots are clear. Paracetamol is in the almost certainly. but not absolutely clear. And the non-steroidals are still in the murky business. I think
Right.
that's fair to say.
Okay.
Particularly the longer half-life non-steroidals.
Just by way of definition from the practical perspective, anyone 3 days a week is really the sort of dividing line. If you're taking allergies, what's your sort of cut-off?
Well, it's 10 days a month.
Right. Okay.
So you know, it's 2 to 3 days a week.
Right.
And the other thing is trend. Now here's again, it's where you've got a big advantage in general practice. You can get people back.
Yeah.
It's if I'm taking 8 this month and 8 this month, and then 9 and then 8 and 9 and 10 and 8 and 9 and 10 and 11 over 6 months. You keep a record of that. I'm clear that they've got a problem because I've got a problem coming on. If I continue to take 9 and 9 and 10 and 9 and 10 and 9 for 5 years, that's not. I mean, there's no change that's going on. So I think that there's when a person's overusing more than 10 days or more per month, it flags you up to think about it. But you do have a distinct advantage in general practice where you can actually get a diary and send them out with a diary and make them chart what they do.
Yeah.
Firstly, sometimes they'll come back and they'll realise, God Lord, I actually use it 20 days a month.
Yeah.
And that really, there's not so much biro on the page, it sort of stops everyone in the room and looks at it. And the other thing is that you've got then a basis for your treatment. So as you challenge them to reduce them, you can see what's going on. It's the benefit of a diary in dealing with this. I think medication overuse.
Yeah.